right. I'm not sure if you heard that, but
I did.
Okay. All right. So Paula, as we go through, if you can tell me what changes in the practice have been introduced as a result of the quality improvement project?
Okay, so we worked with both Tri-State Community Health Center, which is the primary care clinic, and then we also worked with Tri-State Women's Health Center, which is their OBGYN clinic. They're both located here in Cumberland, and we worked with both of them. What I would say was, and you have the statistics there that you can see everything, but I would say the biggest thing that, and the most successful thing that came out of it was, and this I think probably happens with any quality improvement project that you do. You think you're doing a fantastic job, and then you see the data and you're like, oh, okay, we can probably improve on that. So one of the changes that we made after we went in, they do not have electronic health records, so we did manual paper chart reviews. And after the baseline data was gathered and we met, and Mary really did some awesome presentation type things and gave us all written information, resources, things like that, that we could look at quality improvement areas. One of the things that came out was they were doing pretty good with referrals for breast cancer screenings for the mammogram, but many of their women would go elsewhere, like maybe they would go to their GYN, and the GYN was the one that was ordering the mammogram and handling, that part of it, because it kind of goes hand in hand with your annual women's health visit. So what we were finding was the docs at the primary care center were talking to their patients about it, and the woman would say, oh yeah, I had my mammogram done, 2 months ago, but there was no follow-up to get the report to make sure that, yes, that was done, and the doctor was never looking at the result. They were just taking the woman at her word. So one thing that we implemented was Tri-State staff would, if they saw where a woman said, yes, I had my mammogram within the last 2 years, they would find out where she had it done. They would have her sign a release of information, and they could gather that information and get the report on the chart so that it was checked off as, yes, she had it, and yes, there's proof that she had it, and the doctor could see what the results were. Once that was implemented, we definitely saw an improvement in the statistics. The other thing, and they had already implemented this on their own. They were implementing it in another. Tri-State has 5 facilities in the Tri-State area: Pennsylvania, West Virginia, and Maryland. So in one of their other, I think it was their West Virginia facility, they had started implementing something called a quality reminder. And basically what that was a sheet of paper in the chart that reminded the physician or the healthcare provider to talk to the woman about several things that they're required to gather from their HRSA requirements. And so they had already kind of tested this with their cervical cancer, and they had a nurse follow up with it, and she would make sure that if there was no documented PAP in the last 3 years, that the quality reminder was put in there, and that let the doctor know, okay, we need to be talking about this. So they added a check-off about the mammograms. If they're over 50, have they had a mammogram in the last year? If they're over age 40, like 40 to 49, had they had one in the last 2 years? So they added that to their quality reminder sheet, and there are several things that are on that sheet: BMI, blood pressure, all kinds of things are on there. But they added the breast cancer screening, the mammogram on there, and we saw that with both the authorization for release of information and the quality reminder, that the screening rates did improve with both of those things. So I think it just made them aware that, okay, we were asking about it and we were being told yes, it was done, but nobody ever really followed up to get that report and get it on the chart.
Okay, so kind of so if you were to describe the changes, it was really bringing awareness with the implementation of the authorization to release and that quality reminder, the piece of paper in the chart. Yeah.
Right.
Do you think that would these changes have been introduced without the quality improvement project?
I know the quality reminder would have, because, like I said, they were already piloting that in one of their other facilities. I'm not sure that the mammography would have been added to it, but so, I would say I'm not real sure about that. As far as the authorization for release of information, I think that was something that came out of this project. And I'm pretty sure that they have, once it was implemented, then they rolled that out to their other facilities as well. So they're using that in all of their facilities.
Okay. Let's take a moment. So the quality reminder was definitely a rollout of the QI.
Yeah.
Okay. Cool. Alignment of the quality improvement interventions with its objective of reducing the disparities in the screening. Are the activities that were undertaken in the quality improvement project, can you explain that approach? Let me go back and let me ask you to explain the activities that were undertaken in the project and the approach. And does that make sense?
I'm not sure. So are you referring to disparities, or I'm not sure what you're asking.
Yep. I'm just going to read it. Are the activities undertaken under the PQI approach, do they serve the project objective?
Yes, I would say yes, because the objectives were, the goal was to decrease mortality among low-income, uninsured, and underinsured racial and ethnic minority women in Maryland through the promotion of sustainable system and process changes within community and clinic settings. So I would say yes.
Okay. And could you recommend other activities that are not a part of the PQI approach that would have served the project objective?
I think the only thing that I can really say was I would have liked to have seen us meet a little more often and have a little bit more back and forth. I mean, I know we talked about this a little bit in our meetings, and one of the most difficult things that we ran into was trying to get meetings set up where everybody was in attendance, because the administration at Tri-State definitely wanted to be involved because it was going to be their decision whether there needed to be those small tests of change made. And so it was, with them having 5 facilities and having the one person that kind of oversees all of those 5 facilities, it was difficult to get the meetings together. I think we could have potentially instituted maybe some other small tests of change if we would have been able to meet more often and maybe try them out. But time just was not on our side as far as that went.
Okay. All right. Thank you. I'm going to move down into the Plan, Do, Study, Act, how you guys did small changes throughout. And the first place I want to start is the planning when we talk about the mapping at the teams. And I know you're at the health department, but were you involved in the process mapping that was happening throughout, at the clinic when they first went there to do any process mapping?
Yes, I believe, and I'll tell you why I'm why I'm so wishy-washy on that answer was once the Komen PQI project ended, it ended in December of 2015, I believe it was. Let me look back here.
Yeah, I think.
Yeah, and so when that grant ended in January of 2016, we got another grant through the CDC, which is what they call a clinical linkages grant, and it was basically doing exactly the same thing that we were doing with the breast cancer, but we were looking at their colorectal cancer screening rates. So what we did was, since we were already going to be in the chart and looking at the data, and we had been for, the last 2 years looking at their breast cancer rates, we just decided we would continue to look at that just as kind of like a bonus for them, because we were going to be looking at the charts anyway. And I'm trying to remember, I know we did process mapping with Tri-State Women's Health Center. We never did get what we needed to do the process mapping for the primary care center. But I was trying to remember, I don't remember if the process mapping happened. Okay, it's all coming back to me now. Mary Joseph did the process mapping, and yes, we were involved. Now I'm kind of talking out loud here.
No, it's fine.
She did the process mapping for the health department and for both Tri-State Women's and Tri-State Primary Care, and then she gave those back to us basically in the format that we had discussed, and we were able to give our input. Okay, you got that right, but that's maybe not right, and we're able to tweak it. So yes, later, in that other grant that I was referring to, I went back and did the process mapping for the other facility. So these grants sometimes run together because we were doing the exact same thing. It was just a different funding source. So kind of had to talk out loud to get that figured out.
I understand. It's like I work with another organization, and they always have multiple grants going at the same time. It's like, how do you guys always do this? I have nursing students. They're like, wow. It's like they're just, they're always trying to control grants. It's a miracle that they get to do the actual work of the grant.
Right.
But, yeah. So when she was doing the process mapping, you said at the health department level as well. Who was she working with at the health department level?
That was me, because I'm the director of the cancer programs, which includes the breast and cervical cancer program. So basically, I just kind of verbally told her, this is what happens when a patient comes in or we get a referral, and walked her through from that point all the way through till they've completed their screening or been diagnosed, and what we do with them if they had a positive breast cancer diagnosis. So I just kind of, and that's how we all did it. Tri-State did that as well. We just kind of verbally told her the workflow, and then she put it into the process mapping diagram.
Okay. And this type of process mapping was effective?
I think so. Because it allowed us to see maybe where the breakdown was. Okay, so the woman says she gets her mammogram, and you document that she says she got it in November of 2014, but here she is back November 2015, and there's no way to show that she really did have it done. Because we all know time gets away from us, and I can say, yeah, I had my mammogram last year, and it might have been 3 years ago, So, so that just kind of showed that, all right, we need to have something formal in the chart to show that it is being done every year.
Okay. And were there any barriers to the mapping? As you guys were doing the process mapping?
No, I don't think so, because Mary really kind of kept everything on task. Of course, we did a lot of communication by email, but once we, verbally told her the workflow of both of the clinics and the health department, then she took it back, put it into the diagram form, sent it back to us, and kind of stayed after everybody until she heard back from them saying, yeah, this looks good, or no, this needs to be changed. So I don't really see that there was a barrier in that step at all.
Okay. And the process maps that Mary produced, they were comprehensive, I think,
yes.
because you guys felt that you could give feedback and everything.
Absolutely.
Okay. Were the process maps, did you guys use them to make changes at all throughout the project? Were these effective tools for making change later
Yeah,
on in the project?
I think that's where that small test of change came in. The other thing that we saw was that their clinical breast, even though we weren't measuring it, as far as formally in the grant, one of the things we were looking at was the clinical breast exams, and we found that there was one provider that was really, really good at doing the breast exam, and there were several others that rarely did a clinical breast exam. And so she talked with Tri-State about maybe utilizing that one provider that was consistent as like a champion of that, and offered trainings and brought, she actually copied onto DISC a seminar that she had went to that was put on somewhere downstate by a radiologist and I believe a surgeon, and talked about how to do a clinical breast exam and all that kind of stuff. So she was definitely able to assist in that area as well.
Okay, great. Were there any process-related considerations that did not receive proper attention, in your opinion?
I'm thinking. Not that I can recall, and I went back through and read through my progress reports yesterday for the time frame of the grant, and nothing jumps out at me. So I can't really think of anything that I would report.
Okay. Now, we have a section in here, patient survey assessments. Did you guys administer from, the health department administer any types of patient survey assessments?
Not with
to utilize in the process mapping? Like, so did you use any of the, any of the patient's feedback ever used in process mapping?
Not with this grant. I mean, here at the health department, we do client satisfaction surveys with our patients. And I think Tri-State does that as well, but we didn't delve into that area that I recall.
Okay. Okay. So were the joint local health department and health clinic systems, were your meetings effective when you started getting into the effectiveness of the approach and working together? Were the meetings effective?
I think they were. In the very beginning, when we first got the grant, and there was a lot of talk between the health department and DHMH as far as how this was going to work, and trying to get the federally qualified health center on board. In the very beginning, I think they were reluctant because they felt as though this was maybe just going to be a way that we could point out things that they were doing wrong, almost like a punishment kind of thing. But DHMH got in on the very beginning and had us set up a conference call with the Tri-State Administration, the Health Department, and DHMH, and really did a fantastic job of laying out the purpose of the grant, what we would be providing to them, which would be just totally beneficial to them. And once we were all on the same page, on the same call, I think it gave everybody a better idea of what was going to happen, and then they bought into it. So I think that was definitely a good thing.
Setting it up, okay. What challenges may have affected the effectiveness of the meeting?
Again, I think I would go back to the fact that we have basically one contact person that we deal with at Tri-State, which is their chief operating officer, and everything pretty much has to go through her. And her availability sometimes is very limited because she is so busy with the 5 facilities. So a lot of times, like Mary would say, okay, it's time for us to meet again. We need to set up a meeting, and She would send her availability dates. I would send my availability dates, and we would not hear back anything from Tri-State. And by the time we did hear back, those dates were gone, and we kind of had to start over again. So I would say just access, timely access to meeting times was a barrier. If we could have met more frequently, I think we probably could have done more to see their statistics rise even more. Not that we didn't see good results, but I think if they would have had more time to spend, we probably could have done more.
Okay. And I guess part of that answer may answer this one. How can the effectiveness of these meetings be improved?
Yeah.
How could just more time with
I think so.
Okay. Yeah. That's it's one of the things, like if you're spread, and I would imagine maybe she has to travel to all of those facilities at some point.
At some point, I'm sure she does. And a lot of the meetings that we did with her, I think her and the nurse manager came to the very first meeting in person, but then the rest of them were teleconference, which was perfectly fine. Mary and I went to the facility and met with the staff, the office manager and the charge nurse. But then the administration, they just called in. But that worked fine. There were no issues there.
Okay. How were the small changes to be tested? How were they identified?
Through our baseline chart reviews that we did. It showed, just flat out statistics. This is what your referral rate is. This is what your actual screening rate is. Screening rate could be higher if there was documentation of the report on the chart. We basically counted a completed screening. We only counted it as completed if the report was on the chart. So that just identified to them that, your providers are asking about it, and the patient is saying that they had it done, but how do you know? You don't really know until you have the proof right in front of you.
All right. Okay. And did the design of the test correspond well with the process mapping exercises?
I think so, yeah.
Okay. And then, Paula, if I can ask you, are you saying you think so just based off of the results that you guys were getting, or did the staff have any input when you were talking to the clinics?
I think both. I think they were very happy to have, very happy to have an outside source looking through the charts, and that was one less thing that they had to do. Sustainability, and that's probably a question that will come. I don't know if they'll have someone that will continue to do this after we're gone. I was referring to that clinical linkages grant that we have, and we'll do our last round of chart reviews end of April, beginning of May, and then that grant is done, so we won't be in there anymore looking at their charts. I would like to hope that someone will follow up on these things, and also with the implementation of their electronic health records, hopefully that those will be things that will be looked at, and they'll be able to flag the charts for people that need screened, but who knows?
Okay. Maybe that walks us into the next question on what improvement could be made to the testing of small changes. And I know you were mentioning electronic health records.
I think that will definitely will help. I think that will help point out maybe trends, and if statistics start to decline, they can look at their process and see why is it declining and what do we need to change. I don't know if I even answered your question.
Yeah, it's just what improvement can be made. Like if the small changes, how was the clinic monitoring the small changes when you guys initially started? And then, if there could have been an improvement to testing the small changes, what could it have been? What could have been done differently?
Well, now with us being in there and looking at their charts every 6 months, what they do, we compile the statistics not only as an overall clinic referral rate and screening rate, but then we break it down by provider as well. So each provider is able to see how they compare to all of the other providers in the practice. And I think that that would be very good. They talk about that in their staff meetings, their provider meetings. You know, as I said before, it's kind of like in your face and you can't ignore it when you see it right there in front of you. I think that would be a wonderful thing to continue, and they would be able to make small tests of change out of that. From what I understand with the electronic health record that they're getting, they will have your electronic health data is only as good as, you know, what you put into it. But they have also gotten another, they're going to be getting another system on top of it, which is called Eye to Eye, and it can kind of extract those things out and show them exactly what the patient needs on what visit without someone having to manually go through each chart. So I think that that will be very beneficial to them and will allow them to see trends and continue to make small tests of change.
Cool. Eye to Eye. It's always new system. It's always new systems coming out. I'm like, oh.
And it's I, the number 2, I. So just the letter.
Okay.
Letter I, the number 2. Because
I was writing. I thought,
I. What is this? Yeah.
2I. Okay. Well, that's creative. Did data collected fully support decision making on which processes to implement and how?
Yes, I would say definitely.
Okay. And what improvements in data collection practices would be advisable to support the project?
I think, again, I have to say electronic health records because, you know, manual chart review is time-consuming. You know, it gets easier the more you do because you know where to look for things, where to find things, but I think if it can be just extracted electronically with a couple clicks here and there, that would be very beneficial. And, you know, their time could be utilized somewhere else much more effectively.
Okay. And Mary had talked about some of, and I'm not sure if it was with Tri-State, but did any of your clinics have problems initially running reports or inputting data into their electronic health records? Now, I know you said Tri-State. Did they have an electronic health record when we started?
No. They don't because they still don't have it. It's coming, but it's not here yet. Okay. So I know Mary talked a lot to them about, you know, once they get the electronic health records, and I remember her saying all the time, it's only as good as what you put into it, and staff have to really get good training because you can't have 5 people putting 5 things in 5 different ways or you're never going to get out of it what you need. So she really did do a lot of education with them about, you know, the importance of training and everybody being on the same page and knowing what to put in and how to enter it based on what you're trying to get out of it.
Okay. So when they were doing data collection at Tri-State, all of this, the data collection, was it done on on a separate sheet of paper, or how were they following the person since it's not in an EHR, or are they just pulling all charts?
So what we did was DHMH gave them parameters. We wanted to see women age 40 and older who had, if we were looking at, we started in 2013. So basically what we were looking at was women who had been seen in the clinic with at least, for the primary care, at least 2 visits in that last year, and of course they had to be of the age 40 and older. With the OB, we only required one visit, because oftentimes if you're not having any problems, you're only going to go to your gynecologist once a year. So we only required one visit. But DHMH did give them parameters, and then what Sheila from Tri-State did was she was able to put that in and then extract out a list of names of the charts that needed to be reviewed in each facility. The staff would then pull those charts, and myself and Michelle Kleiss, who was in the grant for a short period of time, we would go once a week and do as many chart reviews as we could get in that 8-hour period. And so it would take us usually about a month and a half to do both facilities and get the chart reviews done.
Okay. And when you say Sheila will put that in, she's putting it into like a registration system based off of, okay.
I'm not exactly sure what it's called, but yeah, like the demographic stuff, all that kind of stuff is in there. It's not an electronic health record or medical record, but they are able to, pull demographic type stuff out of it.
Right. I guess they use a system to check people in and out. So.
Sure. Right.
Gotcha. Okay. Okay. Did I already ask what improvements in the data collection practices would be advised? We went through that.
Yeah.
Did the analytical tools and methods used that were used, did it allow you guys to leverage the data effectively?
I think so. The only hard part was, everything was done on paper. We had a sheet of paper, that had all of the demographic information that they were looking for, like date of birth, male, female. Of course, for this grant, they were all female. How many visits in the last year? Did they have insurance or were they uninsured? All that type of thing. But then, of course, was there a mammogram done within the last 2 years? Was there a clinical breast exam done within the last year? So you go through the chart, you mark off all that stuff, and then after it's all said and done, then what I had to do was go through and input all of that into an Excel format, and that's the way I was able to generate my statistics. So that was definitely very labor-intensive and time-consuming.
I can imagine. Yeah. We're as we're going through the data now, we're doing some re-editing, and we're like, oh wow, because we didn't know how we would get the data, and so the quantitative guy, he's trying to recreate, and he was like, oh yeah, he was like, I can imagine that this was labor intensive on the front part. I was like, yeah.
Absolutely.
Especially if you don't have a system, where you can pull it all out. You usually have, some bigger companies have a whole department that just does that. So
sure.
Kudos to you for getting that done. Were there any analysis of available data that were not available to support decision making?
I don't think so. Not that I can think of.
Okay. And how can any analytical support be improved to strengthen its relevance to the project?
What do you mean by analytical support? Like trying to analyze the data?
Yeah, as you look back and you say it was laborsome, so are there any other analytical, how could some other analytical support, be it, do you think additional persons or a system, or maybe if people had put them in, I'm not sure.
Yeah, I think it would have been helpful to have, once we completed the chart review, it would have been nice to have someone else input the data into, whether it would have been a program that could automatically, spit out the statistics or whatever. That would have been nice to have, something where, you've got your data, now here you go, it's all yours, and then you come back to me and tell me, based on all of your chart reviews, this is what we found. That would have been nice to have something like that instead of having to data entry everything into basically Excel is what we used, and then, figure out how to calculate it from there.
Okay. And moving on, on the implementation part of the changes, were all proposed changes identified as beneficial, that were beneficial for the project introduced?
I think so, because basically we only did the two, which was the release form signed by the patient when they were in for their visit, and then the quality reminder sheet. And I would say both of those things were beneficial.
Okay. Were there any barriers to implementing those potential changes or these changes?
They were just a little, I know in the very beginning we talked, once we had the process mapping and saw where there was a need, it seemed like it took a little bit of time for Tri-State to actually get us the form that we needed. And again, that was due to not being able to set up a meeting to say, okay, this is what we need and how are you going to get this to us and those types of things. So it seems like once we decided, okay, this is where the breakdown is, we're not getting the report on the chart, and this is what we can probably do to maybe improve that. It just seemed like there was a long lag in time before we actually got the release from them to start putting in the charts. What we would do was when Michelle and I would do the chart reviews, if we saw that the patient had reported they had the screening but the report wasn't in there, we would put the authorization in there with exactly what they needed. They needed a mammogram, they needed a colonoscopy, proof of it. So that was very helpful to the staff, because when they saw that, then that was just one less thing that they had to do. They knew that someone had already looked at the chart and this was what was needed. So I would say, again, just the difficulty in getting a meeting set up, it kind of delayed the plan of implementation of those two small tests to change.
Okay. And were there any factors that made it easier to introduce the change?
I think Mary Joseph, she was a big factor. Yeah, she really, she was very good about emailing, where are we with this, reaching out, and kind of trying to keep everybody on task as much as possible. She was always that little reminder that, hey, we're still waiting on this, or, so I think she was definitely, that was right up her alley.
Yeah, always. She's like the alarm clock. Like, oh, I'm keeping you guys.
Absolutely.
We've hit this date and we haven't had any traction. Let's go.
Yep.
So, in terms of Mary Jane Joseph, was she effective as a facilitator?
Yes, she was. She always, if she was going to suggest something, she always had articles, some type of resource to fall back on to say, look, this is what I'm looking at. They tried this. Why don't we do this? And was always offering, okay, we know this needs to be done. How can I help you make it happen? Like with the clinical breast exam, we saw that there was definitely a deficit with providers doing clinical breast exams. So, she talked at length with the administration as far as, are they not comfortable in doing them? Have they not been trained to do them? If we offered someone to come up and do a training, would that be helpful? So she wouldn't make a suggestion without having some type of a solution of how it was going to happen, and I think that was really, really good.
Oh, perfect. And I think you answered this one. What factors contributed to their effectiveness or lack thereof? And I think when you're saying that she would talk at length with providers, the information that she provided, she did a needs assessment and she would always have a solution.
Right.
Okay, great. Are there any ways that her performance could be improved?
I don't think so. I was very impressed by everything that she did. And even to this day, she still sends me information. Thought you might benefit from this article. So just because the grant's over, she hasn't stopped communicating.
Oh, perfect. Yeah, she sent me, when we met with her, she was fantastic. She had already brought stuff to anticipate the things that we may be interested in. And then even after it was over, she sent a ton of stuff via email.
Yeah.
I was like, she's like a walking encyclopedia.
She is.
So it's very good. I think her years of experience and her dedication to this is phenomenal.
Absolutely.
Yeah. Did any characteristics of Tri-State or its practices complicate or help the intervention?
As far as complicate, I think I would go back again to just the barrier of not having time and not being able to get everybody together in a timely fashion. I think that would be the complication there that, slowed things down a bit, even though I think we did accomplish what we had set out to accomplish. It slowed it down for sure.
Okay. Have these issues been, so since these issues had been identified through the project, have they been addressed in any way, even if partially?
I don't think, if they've been addressed, they haven't improved. I'll just say that.
Okay.
And I'm not sure how you would even go about that, because like I said, there's, one person can only do so much. Yeah.
Okay. Just in implementing the project, were there any unintended consequences, any downsides or costs to implementing this PQI approach?
Not that I can think of. I will just tell you that we've always, even before this grant, we've always had a very good relationship with our federally qualified health centers. They send us a lot of our referrals for both breast and cervical and colorectal. And I would say one unintended consequence maybe, which was a good thing, was you actually got to go over to both facilities and meet the people in person that you talk to several times a week on the phone, put a face with a name, and build somewhat of a more open relationship with them. And I think that was very helpful for us and for them.
Yep. You can do. I used to do case management. You could do telephonic case management, and then when you go into the hospitals and you actually meet the other case managers, it's like
Yeah.
It seems like after you meet, business after that becomes totally different. The interactions, everything, it becomes, I can really connect and relate to you. So, yeah, good. Anything else that you want to tell me about the project, and from your standpoint, or that you think we should know in terms of looking at best practices or lessons learned as we move forward?
I know we talked about this a lot when Mary would come up and meet with us, and I think the grant for us opened our eyes as far as we're going in and we're reviewing their chart. We are looking for preventative screening rates, and that's what our main focus is. And this needs to be done, and if it's not being done, why isn't it being done? But from a primary care or GYN standpoint, yes, that's one of the check marks that they need to check off, but a lot of times they get people in there that, are having a life-threatening issue, whether it be medical or psychiatric, and the last thing on their mind at that point is talking to somebody about a mammogram. So for me, the impact that it had on me was it really helped. I've never worked in a primary care setting. I worked in the hospital, but never in a doctor's office. And so for me, it just really was eye-opening. Like, they have all these things that they have to do, and they have to accomplish it in a very short period of time, probably 15 minutes or less, because that's about all they have that patient for. And we're harping on them about a mammogram. So it was just kind of nice and helped us to see where they're coming from. Sometimes I think we can be a pain in their side, or they can be a pain in our side, but it really helps both of us see where each other was coming from. As far as best practices go,
And I'm going to just move for a moment.
I don't know what I would say about best practices other than the people that work in the offices are very, very good, and if you ask them to do something, given a little bit of time, they will usually do it and help figure out a way to make it work. So I think in a grant like this, getting the frontline people involved in it as much as just the administrative people is very important because it helps them buy into the whole process.
Right, and yeah. How involved were they, the frontline people? I know that Sheila took a big part, a big lead, but was the frontline involved in like process mapping or thinking about?
The office manager and the charge nurse for both the primary care site and the OBGYN site, they were involved. As far as any other staff, no, that's the only ones that were involved, other than Sheila.
Okay.
But I definitely got the feeling, and still do get the feeling, that they, the office managers in both facilities have an excellent working relationship with their people. And, if they relay something to them and explain this is what we need to do and why we need to do it, the staff usually seem like they will buy into it and help out.
Okay. And then, Paula, can I ask you, during this time, and this is one question we haven't asked a lot, but were providers brought into this early on, or they were just, how were they involved in this?
I didn't see any, I was not in on that piece of it. I do know that when the grant first started, they have provider meetings, and I'm not sure how often they have them. It might be monthly, but I'm not 100% certain about that. But they were informed that the health department and the Department of Health and Mental Hygiene were going to be doing this grant and in the records and looking at these types of things. And then each time we had data, both the baseline data and then the 6-month, 12-month, that data was shared with the providers in their staff meetings. We were not in on that, but it was shared with them. And I truly believe that they talked about it, because otherwise I don't think we would have seen an uptick in their rates. So I do think they were doing it, but no, we were not in on that piece of it.
Okay, so probably Sheila was maybe a conduit to all of that information. Okay. Okay.
Were you able to get in touch with her? I was just curious.
I did. Who did I get on the phone? I got not Sheila on the phone. I got the nurse manager. Let me pull up and I sent them an email. Let's see. So yeah, I got in touch with Diane Markwood.
Mm-hmm. Okay.
And she said that she needed to get in touch with Sheila, and Jessica, the nurse manager who was there, was no longer.
Really? I didn't know that. Okay.
So she was telling me that she was no longer there. So I sent an email, and I'm going to follow back up on an email. But if there is anything, I'm not sure of how often you and Sheila speak, but if you could make that connection or introduce me, that would be perfect. Just to get in and so we could get some questions answered and speak with someone at the clinic level.
Okay. Yep. I will give it a shot. I know they're in the middle of rolling out their electronic health records in one of their facilities. So I've sent her. I have a couple different grants that I work with them on, and it's been difficult to reach her these last 2 or 3 weeks because they're, usually the response is, we are head deep in electronic health records, I'll get back to you as soon as I
Wow.
can, and that's pretty much where it's left. But I will certainly try.
Okay. We can only try, and I'll continue to reach out. But I do thank you for that, for doing that.
Sure.
Thank you so much for your time. We have come to the end, and I think that you've given me even more insight, because I did not know how it would how the local health department was involved. Even hearing that you were also a part of going to the facility and looking at the charts. When you said a Michelle was involved as well, is that Michelle? You mentioned Michelle?
Yeah, she worked for a time in the breast and cervical program. She was our outreach worker. And
Okay.
when we got this grant, we utilized her to help me with the chart reviews.
Okay.
But somewhere in the midst of all that, she's still here at the health department, but she's in a different program now. So once she left and was no longer in the grant, then it was basically just me.
Doing chart reviews.
Right.
Lucky you.
I know.
Oh my gosh. How often do you do chart reviews, like in all of these grants that you have? Is that always like a part of it?
In one other one, it is, in addition
Okay.
to this clinical linkage. So I also work in reproductive health, and we contract our services out to the federally qualified health center. So one thing we do is usually twice a year review some charts, but it's not nearly, I mean, it might be 10, 15 charts at a time. It's nothing on the scale that the clinical linkages in the Komen PQI grant were.
Okay. Oh, that's cool. The 10
Yeah.
to 15 charts is doable. That's doable, but yeah. Okay. Well, thank you so much, Paula. Do you have any questions for me or anything?
I don't think so. No, I don't think so.
All right. As I'm going through, I don't think I may need to reach back out to you, but if I do, I'll send you an email
Okay.
and try not to disrupt your day. But thank you so much for taking time to meet with me and give me further insight into the Komen PQI. Thank you so much.
My pleasure, Randy. Thank you.
All right. Enjoy the rest of your day.
You too. Bye-bye.
All right. Bye.